from lovely Durango, Colorado tonight. Thank you to everyone who's attending in person, and thank you everyone who's joining us online. I know it's a Friday evening and we appreciate that you're here. We're here tonight to talk about MS with Dr. Enrique Alvarez. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. And I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our educational programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Some recent videos that we've posted include our Spring Education Summit, which covered the topics of spasticity, current clinical trials, the potential of stem cells in MS, and treatment philosophies over a lifetime. We've also explored the topic of the why behind MS through genetics and environmental factors in a webinar, all of which can be found on our YouTube channel. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are available free of charge to anyone interested. And now I'll introduce you to Dr. Enrique Alvarez. Dr. Alvarez is the Vice Chair for Clinical Research at the Rocky Mountain MS Center at the University of Colorado. He's a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. We had a lot of great questions submitted at registration today, and we'll get to as many of them as we can. And just a reminder that today's presentation is for informational purposes only. All decisions regarding MS treatment should be discussed with your neurologist. With that, I'll turn it over to you.
Awesome. So for people that haven't done these conversations, it's a really easy format. You guys ask questions and I try to answer them or make up something as it goes. So we'll just get started. Anybody have questions out there, burning questions they want to start off with? She had a bunch of them already from you guys, so that's all right. So we could just start with Kelsey if you want.
All right, so we'll get started. I know normal people can benefit from heat stress, i.e. through sauna use, and get heat adaptation. Is this true for people with MS as well? Can heat tolerance be improved through heat exposure?
Yeah, so this is one that, yeah, so a little bit louder. So the question was around, is there a benefit to doing like heat exposure to try and like train for that, given the heat sensitivity, you know, that MS patients tend to have? I would say I don't know much about this area, so but I think it's one of those things that being exposed and trying to push things to try and see what you can tolerate is always a good thing, as long as you keep doing it gradually and slowly, right? So you don't start running a marathon by like running a marathon. You kind of build up kind of gradually to see what you can do. And I think with heat exposure and trying to kind of see what you can tolerate for, I think this makes sense, and trying to kind of know what your boundaries are is what you can tolerate. I would say, for as much as we hear about people not tolerating heat, you know, patients with MS, there's patients that don't tolerate cold. You know, it's the complete opposite for some people. It's less often, but, you know, so again, you have to know how you react to things. And I think that that becomes really important, you know, when you're living with MS. You know, I think when I'm talking about patients and, you know, what's a good exercise, what should I be doing, you know, I think it's whatever you like doing safely. So if you have balance exercises, don't get on a bike ride and ride straight away from the house and then being like, oh crap, I can't get back home, right? So do some loops around, try to figure out like, you know, if I start having issues, I'm not that far away from home, I can take a break, I can cool down, that kind of stuff. And you want to kind of gradually increase that. It gets tricky. Some days are hotter than others, to go back to the heat thing. So you have to kind of know sort of like, I can do this in 80-degree weather, but I can't do it for 100-degree weather. Or for me, it doesn't really matter. So I can do it in any of those kind of conditions and be okay. And so that's where you have to kind of test it and try out and kind of know what your limits are and how you're doing it. Recognizing that if you have a urinary tract infection or a cold or something else like this, you may not be able to do your normal thing. So you might need to be a little bit more careful on some of those days as well. So a lot of these things that, fall, I think, sometimes under common sense, but it's helpful to hear it, like, we still have to remind kids about some of these things as well. So, yes. And he remembered the mic. So that's an important point. Grab the mic if you're asking questions. Yes.
With the heat issue, is there any concern with being exposed to heat and having some irreversible effects from it? Like,
Awesome question. Yeah. So the question was, I'm not sure that that's looping around, but maybe it's for the people there. Okay. So I'm come up forward a little bit. Is that okay from okay? So the question was a little bit about, is there any concern for permanent damage from heat if you're heat sensitive? And I would say it's the same thing with exercise or after an infection or anything like this. So we call those events sort of like reoccurrences or pseudo-relapses, pseudo-exacerbations, pseudo-attacks, those kinds of things. So it's the old symptoms coming back. What I describe them as a little bit is like if you pulled an all-nighter the next day and you try to take a test, your thinking is going to be slower. You're not going to do as well. And that's whether you have MS or not. You're just not going to do as well. And so if you are, get good sleep, everything kind of comes back. And that's what the hope is with this stuff. It depends a little bit sometimes then on what the issue was. So a great example I heard actually yesterday at a call we were at was, what if you, had COVID and you had some deconditioning or other things like this? It may not fully come back because of the damage that was associated with that, damage to lungs. You might have more fatigable issues or those kinds of things. But again, from an MS perspective, the damage to the nervous system that was associated with that part of it should go back to its normal self because there's no damage associated with that. So perfect. Is that clear? Cool. I could maybe follow up with your question then. I put you on the spot. I pointed at you, sorry. So the question, the gist of the question, and see if I get this right, because I'm getting old and my bifocals are not working very well. Oh, perfect, please. So the idea was, how am I, why am I getting worse if my MRIs keep saying I'm stable? And I think when I think about MS, that I think about it as almost two diseases. So there's the component to it around relapses. That's the piece that we're really good at treating nowadays. We can, that's the inflammation, the stuff that causes bruises, the little white spots in the brain. And those are the things that we can measure really well and kind of see. And again, pretty much at this point, stop. We have drugs that we really think like maybe 1 in 200 people might have some new MRI disease activity on some of these drugs. The problem is with progression. And with progression, it doesn't leave little white spots. It tends to be a little bit more of a degenerative process. We see a little bit more brain shrinkage. And we all have some brain shrinkage. We're all getting older, unfortunately. And so there's a certain rate of progression of brain loss that we all have. And the rate of progressive MS is not that different from that rate that we tend to see from getting older. It's a little bit more, but you're talking about 0.25% per year, like 0.25%. To put that in yeah.
I'm primary progressive.
Yeah.
So, and nothing ever changes on the MRIs.
Yeah. It
But the
changed
body
at
has
some point.
changed incredibly in the
Yeah.
last 2
So the
years.
question was with primary progressive MS that the MRIs have never changed, but the symptoms are gradually getting worse. And that's true to a certain extent, because to make a diagnosis of primary progressive MS, we still need to see the little white spots on the brain MRI that occurred at some point. And so that inflammation, that damage that occurred from that stuff happened. It just maybe was in areas of the brain that didn't give you symptoms. So remember, the brain, has a lot of stuff that does things that are much more subtle than other things. And some of the things are really hard to measure. So in the mornings, I have my coffee. I am not as sharp as maybe once I fully wake up, right? And have some caffeine and kind of get going. So if I lost a point or two of IQ, right, from one of these lesions, I probably would not notice it. Now, if I have 5 or 6 of that and my IQ starts to drop 10 points, that becomes enough for me to notice it. And that's one of the biggest challenges that we have, right? Memory, attention, concentration, they fluctuate a lot. By the end of the day, I'm tired. I'm not thinking as well, as fast as I normally might in the mornings, right? But if I'm walking and I lose a little bit of strength, damn, I'm going to notice that pretty fast, right? You're going to start losing your balance and things like that. And so you're going to notice that. Now, my analogy is always Arnold Schwarzenegger. That might date me a little bit. But if he got a little bit weaker, right, he'd still be strong enough to kick my butt. So he has a lot of buffer. He has a lot of reserve that he can really do well with. And, younger people have a lot of reserve. And as you get older, that reserve goes away because, again, that gradual progression of that atrophy, that brain loss that occurs really slowly and gradually, just kind of keeps chipping away at things. And it keeps chewing away that reserve. So if you have a lot of buffer, over time, that buffer becomes less and less. And so it makes it really tough. To go back a little bit to the issues with measuring brain volume is that the brain volume changes throughout the day more than that 0.25%. Because at night you don't drink, so it tends to dehydrate a little bit. You drink during the day and it hydrates. Hormones affect it to some degrees as well. The MRI machines, if you go from MRI machine to another MRI machine, your brain volume can change a lot because of how they measure it. We had a research MRI machine and we switched to a different one about 10 years ago, and everybody's brain grew 2.5%. Yeah, I know. So, we just need more of them, and then we can just keep working at it. So I think that's been the challenge. And so we've tried to incorporate the brain volume changes and how much that changes in our clinical practice. But I've seen those numbers go like this from MRI to MRI, and then people come in and they say, how come I went from the 90th percentile to the 15th percentile to the 73rd percentile? And I was like, it's just, we're not good at measuring it. So it's getting better. There's a lot of efforts kind of going into this and trying to normalize things, correct for different MRIs, trying to do the MRIs at the same time, trying to get people to hydrate before MRIs, all these other things. So I think we'll get there at some point. We're just not there yet. What else you got?
Can you talk a little bit about the clinical trials for BTK inhibitors, and particularly what they might mean for smoldering inflammation?
Yeah, so BTK inhibitors, in our context, being Bruton tyrosine kinase inhibitors. This is a group of drugs that is actually already approved, not for MS, but they're being used in the cancer world for patients who have lymphomas and things like this. And it prevents the activation of B cells. And it is such a popular target that there's, I think, at least 6 to 8 of them in different stages of clinical trials. The question comes around a little bit because we heard about the first one that finished its phase 3 trials. The phase 3 trials are the trials that kind of lead to getting the drug approved. And unfortunately, it did not look great. So evobrutinib went up against teriflunomide, and it looked just as good as teriflunomide or Augbagio in that clinical trial. There was no difference in any clinical measure, MRIs, or any of this other stuff. And so it made it really, it was kind of a little bit of a concern for all the other 5 to 7 BTK inhibitors that are kind of coming through the pipeline to kind of, depending on how excited you are. Part of the question a little bit was around some of these BTK inhibitors have had issues with liver in the first few weeks when you start the drug. And so they've been put on what they call an FDA hold. So in the United States, we have several of these trials. We cannot recruit any more people into these trials. It also means that as those patients that finish the phase 3 trial, usually they would switch if they were on the other drug to the BTK inhibitor. We can't switch them to the BTK inhibitor, so we are continuing the blind a little bit longer than usual until the FDA kind of looks at the data and they determine kind of what they're going to do with it. By probably the next couple of months, we'll hear about the second drug called tolebrutinib. And there's been a lot of interest in that set of trials because they actually did a lot of progressive trials. So they did actually 4 studies, 2 for relapsing remitting MS, 1 for non-active secondary progressive, and 1 for primary progressive MS. And so if there's an effect maybe on progression, but maybe not relapses, then we might be able to see a difference in that set of trials than maybe we were not able to see in the evobrutinib trials. I would say sometimes we cluster these drugs together, but just to highlight that they're all very different drugs, and the targets of these drugs are a little bit loosey-goosey. I mean, we talk about them being sort of like, you know, they really go after BTK and that's the target. But a lot of these have extramarital affairs. And so they'll kind of bind to other proteins and they kind of work on similar drugs. And so they're not as clean sometimes as we think that they might be. The 4th one that's kind of coming up, remyelination, might get approved for urticaria, and so far it did not, like basically itchy skin, and it did not have any liver signal associated with it. Because of the issues in the class, I think they've been unfairly kind of targeted a little bit for this. So like the one for Genentech has had only 1 real liver issue, and because of that, it got put on an FDA hold. So I think there's just a little bit of like, we're not sure why this is happening, so let's just take it with pause. In the rest of the world, they're proceeding with the trials. It's only in the United States that are getting put on hold a little bit. So I think there's a lot to come for this drug class. But again, this was sort of going to be the next wave of drugs and maybe still might be. But so far, there's been a little bit of a dampening and concerns with that. And that's that smoldering inflammation. They're kind of looking at that progression and in the sense of not big, bright white lesions, you know, the relapse lesions, but more of, is there kind of slow, gradual changes? So some of them, the terms kind of associated with them have been slowly evolving lesions, so not a lesion that pops and stays on an MRI machine, but a lesion that's there and it kind of just slowly grows over years. That's really hard to sometimes detect unless you look at that MRI and go back like 3 or 4 years and you go like, holy crap, that lesion really got bigger. Paramagnetic rim lesions. So one of the other features we realize is that some lesions will have a rim of iron on the outside. Those seem to be a little bit more destructive. And so you can do some sequences to look at that. We don't know, but why do they have the iron rim around them? I think the thought is that the macrophages, the cells that go in and try to clean up stuff, the cleaner upper cells, are picking up blood products or other things like this, and that's where the iron comes in. And so if there's a little bit more damage, then you might see some more of those products kind of coming around. Iron in the brain doesn't work very well. It's very, if you ever get a little bit of blood in the brain, it actually hurts a lot. It's very irritating, and so you want it to kind of stay within cells, and so it gets sequestered or tied up. And so those cells, like, they just don't move. Like, those lesions are then usually present for like years and years and years. So whether they're active or not active, so these have been things that I would say are associated with these parts of MS. But is this the hallmark of a progressive MS patient? I think the answer to that might be no, but I would say we don't have the information yet that we really need to kind of be able to answer those questions.
I think we'll just wrap up kind of the future of MS drugs all at once. So a couple of questions. Are there any other drugs that are on the horizon for progressive MS? Is remyelination something that we can hope for? And then we also had a question about, is AI being used to speed up drug research, similar to vaccine research?
Yeah, that's a lot. Okay, so yes, there's a lot of other drugs coming through. So that's kind of the big wave. Those are a lot of the big phase 3, the big trials that are kind of coming up. The other drug that entered kind of phase 3 trials right now is something called frexalimab, which is an anti-CD40 ligand, again, alphabet soup stuff, but it's looking at another type of inflammatory cell that is present in MS. And they're doing trials in progressive MS and regular MS. We tend to think about this as being more for inflammatory MS, but one of the observations was that progressive patients actually have higher levels of the CD40 ligand than patients without progression. So it does make some sense to kind of look at those patients as well for that. There's a lot of interest looking at stem cells and things called CARs or cell therapies. Stem cells being much more of trying to kind of repair what's broken or change the immune system. The CAR Ts, which is kind of the first wave, but then T is T cells, but there's also CAR NK cells and the target. So these are basically cells that have been manufactured. For the most part, what they do is they take cells from you, they make them so that they target certain things, and then they put them back into you to take care of it. So the first wave of these have been to actually take care of B cells, so kind of like rituximab, Ocrevus, ublituximab, ofatumumab, that target B cells by taking out CD20s. CD19 is a very similar target on these cells. These cells can go in and try and target those cells. And the excitement is that those antibodies don't make it into the brain and the spinal cord very well, but these cells have a chance to actually make it into the brain and the spinal cord. So it might give us an advantage in their ability to go after those cells that we've not been able to target in the past. That was one of those things that we were really hopeful that those BTK drugs would be able to do, because again, those cells we think are kind of protected inside the brain. So if we could target them, that would be kind of cool to be able to kind of get at. So we'll learn about this a lot more. But there's a lot of other molecules, there's other cells, and so those are all at the phase 1 phase, so meaning we got at least another probably 10 years before they kind of come out. But we are probably getting involved, and I've heard of probably like 7 or 8 trials, potentially at the university that are kind of gearing up to kind of get looked at with variations on a theme. That was future drugs, but then you also asked.
Is AI?
AI. So AI is being used sometimes for maybe more easier things in some of the trials. So as easy as like, we put a lot of questions into the trials. So I know that AI, for example, is being used to try and answer and sort out those questions here. So simple things like that. But it's also being looked at in the context of like trying to design drugs and looking at targets and things like that. And so, all that stuff tends to be a little bit more proprietary, so they're not telling us about it. But for example, some of the larger data sets that are being looked at are getting fed into computer systems to try and identify different parts of the brain. So one of the things we've always said is by looking at a brain MRI, I can't tell if it's a relapsing patient or a progressive patient. And so they're feeding this into computers and trying to be like, in the computer, pick out who's progressive and who's relapsing. they're picking up on a lot of the same things we do. And so at the population level, they're really good at doing these things. You know, if you have a lot of lesions, you're probably more likely to have progression. You know, if you have a lot of atrophy, you're more likely to have progression. So it's trying to kind of sort out like how useful is it really at? And that's the stage we're still at.
If I experience numbness in a new area of my body, would that be classified as a new symptom?
Yes. So is numbness in a new part of the body classified as a new symptom? So yes. There's always a tricky part to this because sometimes there'll be new symptoms that are maybe sometimes associated with MRI changes. And so those are the kind of those pseudo events we talked about at the very beginning. But if we're betting people, things that are new, we would bet would have much more likely to have new lesions and new inflammation associated with it. You know, the things that make us think about pseudo stuff is, hey, I'm having my usual numbness in my feet that I normally get towards the end of the day. It's maybe getting a little bit more constant, more, you know, more number, if that's a word. You know, I just can't feel it as much as I normally would. Those kinds of things. And so when you're looking at those patients, sometimes it's a little bit harder to kind of sort out is that new stuff or is that worsening of the other stuff, and are you looking at progression? And so sometimes, you know, a lot of times that's where, you know, getting MRIs and things like this can be really helpful to try and sort this out.
So if you've got some numbness or tingling that's a little bit different, or other symptoms that are showing up, things like potentially hallucinations or vision problems, what are the things you need to be bringing up to your neurologist?
Yeah. So anything new, I think it's always good to talk to your doc about. You know, definitely, you know, I would say the core symptoms that we tend to think about that are kind of more associated with MS is going to be double vision or loss of vision, weakness or numbness, balance coordination issues, and bladder stuff. Notice I didn't say fatigue. That's probably that is the number one symptom in MS. But it's the number one symptom with pretty much everything out there, right? So some of these symptoms are just more specific to MS and they help you kind of pinpoint things to MS, but they could also be coming in from something else. All those core symptoms, right? We can get that with strokes, we can get that with other things, right? So trying to kind of get evaluated for that stuff and understanding how fast did it come up? How long did it last for? You know, those things. Did it behave like a bruise? Or did it behave like something that is growing much more slowly, like a tumor? Did it grow much more, you know, did it come on all of a sudden like you would expect a stroke to do? Those things. So that's why you get asked so many questions when you do get called in. And nowadays, because we have such good drugs, the first few questions that you get asked about are, do you have a urinary tract infection? Do you have something else like that? And so trying to sort out, is it a pseudo event, becomes important. Even if I didn't mention hallucinations, right, or other symptoms like that, it's important to recognize that's not normal. And so it might not be an MS symptom, but we still should try to figure out what is going on. So, you know, it might be a pass on sort of like, hey, that's not us, but at least you should talk to somebody about this and see what's going on. You know, we should chat about it and kind of see, is there something that we can understand of what's going on? You know, who should you see for those symptoms? Should be part of that discussion as well. I think especially at the beginning, it's hard to know. MS can do so many different things and it behaves so differently on everybody that at the beginning, it's hard to answer these questions. You know, after you've had MS for 5-10 years, you're kind of like, yeah, I got it, you know, and yeah, I kind of know where I'm going and what's happening. And so at that point, then it's a lot, you know, kind of when you have to talk to the doc about certain symptoms or not. But I think at the beginning, it's just easier to kind of just have those discussions and kind of bring them up.
Does MS ever cause significant behavior or mental changes, personality changes?
So the question was, does MS ever cause behavior changes and mental health changes? I mean, obviously, yes, it can. There are certain things that you tend to see more of than other things. There are some things that I say would be primary and some things that are secondary. So what do I mean by all that? So MS, for example, memory problems are probably the biggest thing. When we talk about memory problems, is understanding that memory really is a big thing. When you talk to the people that specialize in memory, for example, they'll talk about like executive function, which is sort of planning. Like, I want to put a table together. Where do I start and how do I go about it? That is less of an issue in MS. In MS, we tend to get more problems with, I call it the squirrel effect, the processing speed. So you can do stuff, it just takes longer. And in that longer process, you might go on some tangent and never kind of come back, right? And so it's a little bit harder sometimes to know like where you're going with things. And so that's where the word finding issues come, right? I'm trying to think of that word, it's just not coming. Let me try and come up with another word and kind of explain it. It's the same thing that happens to anybody when they're starting to be a little bit slower.
Used to refer to an additional
There
person.
you go. And so, can you get back? See, we're using AI tonight, like for good or for bad. We do use, compensating strategies, and people without MS still have some of these issues as well. Now, hallucinations are less likely, very unlikely to be from an MS perspective, but if, at least as a primary thing, so primarily caused by MS, but MS can a lot of times cause problems with sleep, cause problems with anxiety. So if you're not sleeping for 2-3 days, we give you steroids, that can do it. Then you can have hallucinations. So the MS didn't cause it, but the stuff we did for the MS caused it. And so that's kind of that secondary piece. And so, yes, it's related to MS, but in a little bit more roundabout sort of way.
Can you describe short circuit fatigue?
Can I describe short circuit fatigue? Somebody asked that question here. I'm not sure what that means. Versus long-term fatigue. Are they asking?
They're online.
They're online? Are they explaining it maybe?
Well, we're waiting to see for more info
Okay.
on that. What are the best treatments for leg twitching during sleep?
So the question is, what is the best treatment for twitches in the leg during sleep? The easy answer for me is it depends. The longer answer is trying to understand what twitching means. So it's a little bit like spasms. There are many things that can kind of cause this. So spasms, so words are kind of what words are and how we interpret them. One of the things I like about practicing in Colorado is I feel like sometimes I use the same words that we normally would tend to use. And where I trained, sometimes words got used a little bit differently. Numbness could be a lack of strength. Things that were numb would be I couldn't move them. And so you have to try and understand the meaning of the word before you could actually answer that question. With that as a background, spasms to me can mean at least 5 different things. So it could be a Charlie horse, less like if it's a quick twitchy thing. You could have tonic spasms. Tonic spasms, I don't know how to describe them in words, but usually if I go to a patient, it's like, do you ever have like an arm or a leg that just sort of goes like this? It draws up slowly, kind of tightens up, holds for 10 seconds to a couple minutes, and then kind of gradually relaxes. And it could be this, it could be this, it could be just about any other kind of movement. It could be usually the same limb, or it could be anything at any time. And those tend to be really painful. It could be restless legs. Restless legs, for people that don't have it, I have a titch of it. It's kind of like itching. So if you don't scratch it, it just builds and you just get this urge of like, oh my God, I got to move that leg. And it just becomes more annoying and more annoying. And then you move it and it kind of just soothes it, kind of like scratching an itch. And then it just gets better. And then it starts to build up again and build up again. And so those kinds of things are treated again with very different types of medicines. You could have periodic limb movements of sleep, which are kind of jerks that occur during sleep. Usually don't wake you up, not painful. Usually it's the partner that recognizes it because, God damn it, she keeps kicking me in the middle of the night. Those kinds of things. So trying sometimes to get a sleep study can be helpful, or kind of sometimes there's medicines that it's kind of like a trial and error thing. You can try some medicine. Try leptol, carbamazepine, or Tegretol can work really well for those tonic spasms. It doesn't work for the other stuff. So if I sprinkle some of this stuff and it gets a little bit better, it's probably that. If I use something like a Requip or a pramipexole, like these dopamine drugs, it works really well for the restless leg syndrome stuff. It doesn't do stuff for the other thing. So then I have a sense of like, that's maybe what that is. So it's a little bit of, when they call it the art of medicine, this is like one area where it's really the art of medicine. You can also have myoclonus. Myoclonus are kind of quick twitching, like jerky movements that are kind of random and things like that. We can see that. Those are pretty rare, but it can be sometimes an MS thing. So yeah, so it's kind of one of those things where you just need to talk to your doc and kind of try to sort out a little bit what the cause is, and then target it with different types of medicines. Yes.
It's not totally my question. I don't want to hijack it, but I think probably many of us, and what I have is just like where your legs just like jerk, like you go to relax, just like a typical MS spasm. So rule out all those other scenarios you said that aren't like typical MS, and they say, well, maybe baclofen or this, but you can take baclofen all day, every day. What's like, baclofen seems to be like easy. They just throw it around. What's like the next step?
Yeah. So the question a little bit is like, so you have this stuff, baclofen gets thrown at a lot of these things as a first line. And so it's a great comment. So baclofen tends to be first line because for most of these things, it works a little bit. In my experience in talking to patients, it cuts most of these things by half. So restless leg, so baclofen is very sedating. So for restless legs, it puts people to sleep. And so then they fall asleep, and then once you're asleep, then you're probably usually often pretty good. So it tends to help because of that. For things that are tonic spasms, it usually cuts them in about 50%. Charlie horses, that kind of, again, makes you sleep through them a little bit. So it because of this or that, it kind of helps. But I notice it doesn't fix any one of those very well. And so myoclonus, which is the quick jerks, are actually less common than a lot of the other things. The other problem too is that a lot of times patients will have 2, 3, or 4 of these, and they tend to feed off of each other. So if you have some restless legs, that urge that of I have to move, oftentimes will kick up those tonic spasms because the muscles are getting so irritated that it induces that jerk to it. So sometimes it's, which one's the worst one? What's the one that I have good drugs for? I don't have great drugs for the quick twitches. I don't have great drugs for Charlie horses, but sometimes we use magnesium for that as well. No, not unless, is there a harm in using magnesium? Thanks. The thing to watch out with magnesium is diarrhea. So if you're having issues from a bowel perspective, just being aware that that could be an issue. Yeah. But yeah, and so some of the stuff is just try drugs, build it up slow, see how it goes. And if you're starting to make headway on it, you go up on the dose. If not, you try something else. and it's just like I said, like it's trial and error, and there's probably at least 5 or 6 different things to kind of try, to see if you can make a dent in it.
And we do have a presentation on spasticity from Dr. Gross from our last Ed Summit. So that is on our YouTube channel. That's a whole 20 minutes on spasticity. Moving on to kind of some of the side effects of the various DMTs. Some people who take Ocrevus get secondary
hypogammaglobulinemia, so low antibody level.
Thank you. What do you see in terms of immune system recovery upon switching to a different DMT? Do the levels recover?
Yeah. So when you're thinking about drugs, trying to kind of see what the benefits versus the risks are, right? I think just from a basic perspective and discussion about this. We love certain drugs. We love B-cell depleting therapies. For anybody that's come up to our center, you know that this is sort of what most of our patients end up on. I think probably 3/4 of our patients are on that group of drugs. Those are great drugs for people that are starting treatment, that have low disability levels. They're the drug class that has data on progressive disease. And so they, for a lot of patients, they're great. The problem is that long term, and you think about somebody who maybe gets diagnosed at age 10 or even 20, that they're going to be on drug for maybe 40, 50, 60 years. Eventually, you probably will drop your antibody levels to a point that's not healthy from a risk perspective. And so, so this is something that we see, and it's usually a couple % per year, over time. So just little by little, it just kind of accumulates. And so there are things that if you pay attention to them, it's not a problem. You need to have an exit strategy. You need to think about what you're going to do with it. But you can't ignore it, because if your antibody levels get really low, you're going to end up with infections associated with it. We don't know what that number of low is. So for different people, it's different numbers, and we can see a lot of infections for people that have really normal levels, and we can see infections for people. Yeah, we can see no infections for people that have really concerning low levels. And so it's like everything, right? So there's different parts of the immune system. Some are able to kind of compensate for things. And so any one thing isn't the factor that really drives most of these things. For this discussion, then I would say then having that exit strategy of like, what can we go to? One of the nice things is, because we have so many options, for patients as they get older and the risk of infections goes up as their antibodies go lower, right? There's a little bit of a tilt in that risk benefit that happens. So high efficacy drugs aren't as high efficacy if you don't have much disease activity left, because your immune system is older, doesn't attack you quite as well. So in older patients that have been stable for a number of years, this idea of de-escalating or stopping treatment is something that we're seeing a lot of interest in and doing. We have a number of studies where we're looking at trying to switch either to fumarates or to the S1Ps and ozanimod, where we're trying to kind of then try to see, like, can those antibodies recover and things like this. Last week, we finished enrolling into one of our fumarate de-escalation studies, and the first couple of patients are finishing off year 1, 2, and we're starting to see that those antibody levels are kind of starting to kind of come up slowly. And so it's one of those things that, there's a chance of being able to recover. I think the tricky part is that might not be the answer for everybody, right? So if you do have somebody who dropped their immunoglobulin levels a lot, somebody who's in their 20s, maybe less so MS, but maybe they're on those drugs because of some other condition where you really have to use high doses of those drugs. Maybe there's not as many alternatives or other things like this. We can do IVIG, so we can do intravenous immunoglobulins or antibodies to try and bring those levels back up. The problem is that's often an infusion every 4 weeks, and to do that to balance out another drug, you want to make sure that that patient really needs that and that there's not an alternative to try and switch out. So for some patients, that might be the right answer. I think for other patients, it's not. And that's where having a good understanding of all the drugs available, what their pros and the cons are, and how to balance those, I think becomes really helpful.
And for more information on that topic, I would suggest Dr. Corboy's presentation from our Spring Education Summit, Treatment Philosophies Over a Lifetime. Sort of in that same vein, how long is it safe to stay on Tecfidera?
Yeah, so Tecfidera is one of the fumarates, so dimethyl fumarate. Like most of these drugs, as long as you're monitoring and things are looking really good, it is good to be on that, it's safe to be on that drug for a really long time. That one particularly can drop lymphocyte counts, so that's one of the things you have to kind of pay attention to. So trying to balance those with kind of infections again and that kind of stuff. Tolerability stuff and things like this. If you're not developing issues with GI stuff or other things like this, then you're good to go for a long time.
On the subject of GI issues, we had a question about teriflunomide. Can somebody expect the side effects to lessen over time the longer that they're on the drug?
Yes. So most of the GI stuff, when the body gets used to it with either the fumarates, so Tecfidera, Vumerity, Ampyra, or with the teriflunomides, leflunomide type drugs, so Augbagio and kind of the parent drug that we sometimes use off-label, the body kind of gets used to it with time. With Augbagio at the beginning, you can have some cramping, diarrhea, and things like this. This was especially an issue because sometimes in the past, and especially before it was being used for MS, it was common to try and load up the drug to kind of get good levels of the drug built up in a system. It can take months sometimes to kind of get that drug built up. And so if you did a loading dose or kind of like these double doses, the GI stuff was particularly bad. And so sometimes that's a trick, is instead of going high, then you go low. So you might try to ramp up slowly. So doing like a half dose, which is an approved dose for Augbagio, and trying to kind of do that for a few weeks or a month, sometimes kind of lets the gut sort of get used to it before you can kind of get to the full dose.
What about with Avonex and hair loss? This person was on Avonex for 30 years. Now they're off of Avonex, but they're still experiencing hair loss.
So Avonex is one of the interferon drugs. It was the second or third drug to get approved in the early mid-90s. And interferons are kind of like what the body makes when you have an infection. So the body aches and all that kind of stuff for people that haven't been on interferons that you get from like the COVID vaccine, what's causing those ucky feelings? It's interferon. And we would give that to people in an injectable form every other day, once a week with Avonex. So sometimes people could have some hair loss from that, feeling like flu-like type symptoms and things like that. One of the things is with interferons, you can also affect thyroid levels. And so just making sure, and that can also cause some hair loss, because usually if you stop the medicine, the hair thinning loss should resolve. But if you're having some thyroid issues underlying there as well, you have to address that and check for that. And that's not uncommon to see with those drugs.
Back to the fatigue question. I also see short circuit fatigue, known as nerve fiber fatigue or conduction block. Do you have anything on those?
So so it's kind of filling in the details around fatigue. So and calling it sort of conduction block and things like this. So let's talk about just fatigue in general. I think there's fatigue and then there's fatigability, which sound very similar, but it kind of means slightly different things. So sometimes we tend to think about more fatigue as in like I'm just tired and things like this. And then the fatigability is you look good, but you wear out pretty fast. And I think this is maybe what they're referring to with the short-term stuff, and that things are wearing out faster than usual. So fatigue, to go back to the examples that we used before about, when you're tired and you're trying to think of a word and you can't quite come up with the word, and now you're trying to figure out how to say that using other words, right? The amount of energy it takes to do all that is much higher. So when I try to explain it to our residents and the students, a lot of times, so I ended up in Denver coming from undergrad in Fargo, North Dakota. And so, if you drive and you follow the interstate, it's a long drive, but, it's not terrible. But if you start blocking, the highway, and then all of a sudden I can make it to Denver, but maybe I'm having to drive all the way to Seattle and then drive back down and get back to Denver, right? I'm not going to make it. I'm going to wear out much more so. So there's a little bit of some of the fatigue stuff is that I'm needing to use other resources to get something done that aren't as efficient. The other thing that we see in MS, and this is where the conduction block happens more so, is when you have nerve fibers and they've lost the insulation. So nerve fibers are actually demyelinated. The way that the signals go down the wires is a little bit like electricity going down the really high voltage cables through that, where you're trying to get the electricity to jump from power station to power station without really trying to kind of make it through the cables as much as possible. So in the nerves, what that means is you actually have the powerhouses, the mitochondria, that expend energy so that they can charge up the stations to make that electricity, that signal jump from point to point. And they only have to do it in little tiny pieces. And so that doesn't take much energy. But now, if you take that insulation away, now you have to ramp up the electricity to make that signal make it through. And instead of being able to jump, it actually has to travel that entire length. And so you actually see these powerhouses not clustered in those tiny little nodes. You'll actually see it throughout the entire part of the nerve that doesn't have that insulation. So you need more powerhouses. It takes more energy. Remember, your brain uses about a quarter of all energy in your body. That doesn't matter if you're working out or doing anything else like this, your brain is still using a quarter of all the power in your body. So if you are then asking it to spend more energy to just kind of get the typical signals going through, it's going to wear out fast. It's going to end up with these conduction blocks. They're going to overheat. There's also problems because they produce a lot of damaging, waste products that the cells then have to clear out. And so it just becomes more and more inefficient, the more of these problems that you accumulate and have. And so in trying to improve that signal, so sometimes if that's the case, sometimes medicines like Ampyra, the walking medicine, can sometimes help. Remember, sometimes the nerves are cut, so it doesn't really matter how you can't improve the signal through a nerve that's not there. So that's some of the permanent disability that does occur as well. And so it's a little bit of this and a little bit of that, and you're trying to kind of see how much of that component is, and that's why Ampyra doesn't work in everybody. Ampyra, Ampyra. That's the brand name. It's now all generic, but that's twice as long and really hard to say. Yeah. Yeah.
Can you talk a little bit more about common experiences with Ampyra?
Yeah.
And then also, what are some other ways that people can improve walking?
Yeah. So how does Ampyra work, and what is it, and kind of what's our experience with it? So Ampyra is often called, we sometimes anecdotally call it the walking pill. I kind of think about it as sort of like a little bit more of an endurance pill. If you want to think about it that way, you don't fatigue out. That fatigability isn't quite as much. I use the rule of thirds. So I feel like a third of patients really find it helpful. A third of patients find it helpful, but not helpful enough to really make it worthwhile taking. and about a third of the people just don't find any difference associated with it. Maybe as an anecdote, a couple anecdotes maybe. So I've had patients that could maybe make it, a mile and a half and make it to 2 miles with the medicine before they completely peter out. That could do, a flight, could, now do 2 flights of stairs. So kind of extending that. I had a patient that I tried it for vision loss in a patient when I was trying things to see if it works. And he came back and it's like, oh, doc, the medicine was great. I found it really helpful. It's like, great. So did your vision get better? And he was like, no, it didn't do anything for my vision. It's like, so, and I thought that was the only symptom he really had. He was like, no, it helped my walking. It's just like, but your walking is normal, because every time I looked at him in clinic, the guy had no problems. He could walk on his tippy toes, his heels. He could, do the sobriety test, all this other stuff. He was describing walking a mile, plus no problems and things like this. Well, it turns out that he was having some issues. He was having some of this fatigability because he couldn't see, he couldn't drive. So he was taking public transportation. And on the way to work, he would wear out and had to stop at a park bench to pick up his energy before he could go to work. It turns out that the Ampyra made him being able not to have to stop at the park bench. He could walk all the way to the office, for his work. He was a lawyer at that time. So sometimes you use things and you kind of get unexpected results, but that's been, so for some patients it's life-changing. And that's, why it's, I think, sometimes worth it trying it. And usually you find out within a few days to a few weeks. So that's the good news. The bad news, so what's the bad news with this drug? So anytime you make nerves work a little bit too well, they can sometimes produce seizures. And so that's the big side effect. So it's about 0.5% risk of seizures. If you've had a seizure, don't try the medicine. Then you're at much higher risk. The biggest problem with this medicine was before they made this drug, there was actually a really old drug that people used to take that had a really short half-life. So people would take it every 2 hours, every 3 hours. And it was very easy to forget, as you could imagine, having to do that. And so people would take it and then take it again. And so the drug levels kind of got bumped up sometimes when they did that, and then get really high. And that's where you ran into trouble. And so with the old versions, that was a lot more common. This is an extended release, so it just kind of draws it out more so. And you take it twice a day.
Talk about that regarding walking and endurance. Does it do anything to help you to pick up your foot?
So yeah, so if that's the weakness part, right? So if that's the part that you would look at. It would affect things that would have an issue with that. And that's a great segue, because I forgot about the whole other second part of that. So what are some of the other things you can do besides the medicine? There's a lot of cool toys out there now that are helping with some of these issues. So when you can't pick up your toes, the traditional device that people would use is an AFO, an ankle foot orthosis. It kind of looks like a medieval torture device. It comes up as an L-shaped thing, fits underneath your foot, wraps around your calf. You kind of strap it on. And the idea is it kind of immobilizes that ankle. So the good news is you won't be able to extend it to catch your toes. The bad news is it's immobilized. You can't move it anyway. So it just keeps getting weaker because you're not exercising. There's a little bit of some newer devices that kind of, instead of kind of going all the way up to the ankle, they wrap around the ankle and then strap to the shoe to kind of just help lift it. And they're attached by strings. The nice thing with that is it'll stop your ankle from going this way because the strings will pull it up, but it'll give you the flexibility to kind of at least move your ankle up some. And it's a little bit more comfortable because it doesn't go all the way up to your calf. The problem with those is if you have problems on the ankle of kind of going in sideways, it doesn't keep it stable enough to kind of keep it from you walking on the edge of on your instep. And so you can kind of roll your ankles and still have some of those issues. So working with like a PT on trying to find the right device for the ankle stuff is important. There's also then electrical devices. So there's, they've been around for a while, but things that are nerve stimulators. So Bioness, Walkaid, Walkaid, have been around for a while, and they're usually been used more so for foot drop. They kind of stimulate the nerve right here. They sense when you're going to push off, and then they shock you. Not the most pleasant of devices, but at least then you're exercising the muscles. So it's something that actually helps reinforce that. One of the things I've gotten a little bit involved with is through a company called Psionic. It's called the Neuro Sleeve. It's more of a muscle stimulator. So it's a sleeve that you wear, and it's got these electrodes that kind of then go onto the muscle, and it works kind of on the lower leg, but also on the thigh a little bit. And so there are devices that start to help actually kind of with the hip flexors, which is the other big muscle that tends to get weak in MS. And that prevents you then from being able to lift your leg up as well. So if you're weak and you can't lift your knee and then your toe is dragging, then that's where you catch it. So it's helpful to actually have both of those muscle groups activated if you can. And it's nice because you can kind of play with it. It's a little bit cheaper and all that kind of stuff again. So there's just options. There's a lot of things out there. And my experience recently is that a lot of times people aren't talking about some of these devices. They are expensive, all this other stuff. Insurance doesn't cover them. But sometimes if it lets you walk or these other things, it's probably the best gym equipment you're going to get if that's helpful for you. And so I think sometimes it's worth trying to see, like, how much does it help me on a trial basis? And I think, if there's trials for them, then that can be really helpful for it. If that allows you to exercise and you can exercise and you stay more active, then you prevent deconditioning, that kind of stuff. So finding exercises that allow you to still do stuff, even if it's maybe not what you used to be able to do, but if it's something, it's still better than nothing. So if that means on a pool and, walking sort of against the lazy river, if that means, being on a bike and just kind of doing a pedal assist, if you have no leg function and it's just hand cranking it, it's still the hard exercise that you're trying to get at. So there's a lot of things out there to try and do that. And maybe you can't do 30 minutes, but maybe you can do 10 minutes and you can do it 3 times a day. Maybe not go to the pool, but maybe some of the other stuff. And those are the practical issues that sometimes I recognize get really hard to do. But it's important to kind of think through and try to see what you can do.
What supplements would you recommend for MS patients?
Yeah, so what supplements do I recommend for MS patients? So usually I recommend as little as possible. Because we've tried a lot of supplements in the last 10 years, and most of them have not really been that helpful. So if you look at sort of like the story with biotin, things like this, where, small trial kind of shows like it might be helpful. You do the big trial and it doesn't quite bear out. So, they're cheap, they're easy, they tend to be pretty well tolerated. Some of these things, but it's really easy to spend a lot of money on some of these things for things that don't have a lot of data to kind of support them. So the ones I do support are usually things like vitamin D is probably the biggest one. Most supplements you will get through food. And, if you're eating a somewhat healthy diet, you will get plenty of these with sort of the foods being, as fortified as they are today. Vitamin D comes in primarily through, anybody know what food? A little bit louder. Dairy, no. Dairy a little bit, not much. Sunshine, but from a food perspective. Spinach, no. Sardines a little bit. I can tell it's everybody's favorite food. Liver, organ meat, yes. So not part of my diet much anymore due to cholesterol issues. I think I can use that as an excuse. But because of these things, we're not getting it through diet. And then from a sun perspective, you actually would make a lot. So sun is another great answer, except for a couple other details. We don't tend to walk around naked. If we're at the pool and the beach, we tend to put on sunscreen, which blocks all that stuff. So you do have to have skin exposed without sunscreen, not usually face or hands. So it actually has to be chest, upper arms, you need to have skin volume sort of assessed. You will make the equivalent of something like 10,000 units if you're, bare chested for like 10, 15 minutes. So you can make a lot through sunlight. It's just we don't get the sunlight that we used to get either. And that's why it's not uncommon when we see patients and are checking vitamin D levels to see vitamin D levels that are undetectable. Not eating liver, not getting the sunlight, those kinds of things. So that's the big one because we just don't see it. How much does it affect MS? With today's drugs, it's probably less of an effect as a disease modifying therapy. But it's one of those things that MS patients fall. If you have thinner bones, then you could fracture. And so trying to prevent, the immobility and deconditioning that happens from that stuff when it's easy to recommend is very important. Vitamin D allows you to absorb calcium. So in the past, we talked a lot about taking calcium with your vitamin D in the low doses. We usually don't, because as long as your vitamin D looks good, you will actually absorb the calcium that's in your regular food. So you don't have to do extra calcium to do that. 30 to 80, somewhere in that range. It fluctuates week to week, that kind of stuff still. 30 is a pretty good level. The Endocrine Society has recommended that. If you look at our institution's guidelines, they just have it over 16. Insider tip, nobody really knows. And sometimes the labs, in order to determine what normal is, they measure it in 100 people and they say the bottom 2.5 and the top 2.5 are abnormal. And so we'll just cut it off here. So if nobody is normal on their vitamin D levels and it gets shifted down, the 2.5% comes out to be less than 16. It has nothing to do with what those levels should be. So unfortunately, it's not great, but we've tried to tell them and they don't listen. So it's all right. On the upper end, one of the things we're starting to kind of find is that when the levels get high, then you start having the opposite effect. You actually start getting rid of calcium, and so you can start to pee it out and thin out bones then on that front as well. There is something known as the Coimbra protocol. It's a Portuguese protocol where they do really high doses of vitamin D, talking like 50,000 units a day plus. I have seen people like pee milk, just not good. And so trying to get levels that high has not been good. They're trying to do it now by limiting how much calcium, so you're not doing, there's just check levels, adjust the doses. There's a lot of genetic variability in how you make vitamin D. So some people will make a lot, some people will not make some. And so, I get sun, I still need supplementation as well. So I think it's just important to kind of keep an eye on those things. Vitamin D is this is a quick squirrel moment. So vitamin D is an interesting piece that sometimes ties when we talk about what causes MS, and we kind of go from environment versus genetics. Vitamin D is maybe one of those missing links there. So when you look at the most common gene associated with MS, it's the MHC, major histocompatibility factor complex. And it's what cells use when they see something foreign, they're called an antigen, to present it to cells that are trying to get activated. So one of those cells is a B cell. Might be why B cell depleting drugs work, less so than about antibodies. Curiously, one of the areas that we find associated with MS is an area in the MHC gene where vitamin D can bind and drive expression of that gene. So if you have higher levels, lower levels, it might drive how much of that MHC you have, how much you can present, not present, things like that. So, we sometimes try to put these things as sort of like, distinct boxes, but again, just to highlight how our body kind of uses all this stuff to kind of mix it all in.
While you're on the subject of kind of potential mechanisms in MS, what are some other risk factors, including genetics and family history for MS?
Yeah. So she was going to be too shy in the back to ask the question, so I'll ask it for her. What is the chances of developing MS if your parents have MS? So the chances of developing MS, and I use rough numbers, these are not exact numbers, they'll slightly higher than that, but just roughly it's about 1 in 1,000 in the general population. It's maybe 1 in 200, something like that. If you're a first degree relative, it goes up tenfold to about 1 in 10. 1 in 10. So, sorry, 1 in 100. So 1% chance. That's much better. Sorry about that. I'm glad somebody was paying attention. Everybody else, you guys failed. You guys were falling asleep on me. No, so it goes up tenfold, but it's still only 1% chance. If you're an identical twin, it goes up to about 2/3 chance that you will go on to develop MS. So even having the same genes doesn't mean you're going to get MS. So that tells you that there's something about the environment that also becomes important. One of the hot topics has been exposure to viruses, particularly Epstein Bar virus. There was a big study done in samples of blood drawn from soldiers because they have no rights, so they draw their blood and stick it in the freezer, and then you can use them for all kinds of stuff, and they're collected for many years. And so they basically, in like 100,000 plus samples that they looked at, they identified 35 people who developed MS and had samples kind of before and after, and 34 out of the 35 were negative on Epstein Bar. They became positive on Epstein Bar. The problem is like 98% of people out of 100,000 were positive for Epstein Bar. So almost everybody has Epstein Bar. So Epstein Bar, by the way, is like the virus that causes mono. So it's a common virus. A lot of people have it. Clinically speaking, we can see syndromes associated after a lot of different types of infections. So personally, I don't know that it's necessarily tied into Epstein Bar virus, but I think there is some tie-in with infections, and the herpes infections, which Epstein Bar belongs to, same thing with shingles, oral herpes, and things like this. Those viruses are so common in us, and they have sometimes the ability to kind of stay in our system and then have sort of reoccurrences. So think like shingles, where it can kind of get reactivated. So I personally think that, it's just exposure to some of these different things that will activate the immune system. Once it's activated, then it's probably a different set of genes that are involved in maintaining that disease. And so looking at the genes associated with severity, for example, are different than the genes associated with developing disease, and that kind of stuff. So I think there's a lot of things that we are still looking at. Other factors that we know is smoking is bad. There's a few others, which I'm blanking on all of a sudden. It's a Friday night. Yeah, and then the worse outcomes, then it's, sort of like other comorbidities. So if you have uncontrolled diabetes, if you're not exercising, and those kinds of things. So there's a lot of things kind of associated and kind of that can make things worse. And, if there's one easy word to kind of say how to do the best that you can, it's wellness. In all of its shapes and forms, right? So eat right, exercise, don't smoke, do all the right things, and all the right things have been associated to be better outcomes, basically, with MS.
And we also, that webinar that I mentioned earlier with Dr. Molly Molman is an hour-long presentation exploring genetics and environmental factors with MS. So that's on our YouTube as well. A lot of areas don't have access to MS specialty neurologists. Can you discuss telehealth a little bit? What it's good for and how to use it?
Yeah. I would say, thankfully, one of our experiments was to try and start using telehealth, and we started using telehealth in early 2020. And we went from like 8 telehealth visits in January of 2020 to like 20 by February and 40 by March, and then COVID hit, and we went to like 1,000 by April. There's a section of like tens of thousands. So I think we've learned how to do telehealth well. Telehealth, as the name sounds, is basically like doing a video conference to do the appointments. And I think a lot of times works really well for most of our visits. Especially if you live in Durango, like it's a long drive and it saves all that time. I think it works just splendidly for most things. The challenge sometimes is if you have a great like new symptoms, if the things are kind of developing, and I really sort of have to like try to sort out a little bit like what changed, what's kind of going on, and I need to see, sometimes people, like to go back to the spasm thing, right? Like if they're occurring and I'm trying to use words to describe it, it's a little bit like sometimes describing an MRI without being able to see the pictures. There's some white spots, they're kind of this big, there's, this many of them, right? Like it's not quite the same as sort of seeing it. And so seeing sort of what that walking looks like and things like this is very helpful. Now, I can tell you that on telly, I can do a lot of those things on telly. Maybe not as well. I might need to have a videographer with you that can hold the camera as you walk away from me or back towards me. I can make you do the sobriety test. I can make you look to the right and to the left if I want to look at your eye movements. So I can do a lot of things. I just can't put my hands and have you fight me and try to say like, is there a subtle difference? And maybe I'm trying to pick those things up, that kind of stuff. And so sometimes for some of those things, it is easier to do them in person. But you got somebody who's stable, and I'm mostly doing a visit to kind of check labs, making sure that we're on schedule for MRIs, that overall things are going as is, that we don't need to do some other test, to answer questions about, hey, when can I look at stopping drug? I'm doing well, been stable for 10 years and I'm 65 now. Yeah, I'm not laying my hand, like for people that see me in clinic, that doing a physical exam is not my strength. I don't do it much. I see you while I'm seeing you in room, but like for the most part, I'm trying to, kind of talk to you to see what the issues are, and we can kind of address them for the most part. And so telehealth a lot of times for that works really pretty well. For that, then we can do them. There's certain rules. So we're not in the United States. We're in the great Colorado state. So meaning I can't practice outside of Colorado. To practice outside Colorado, I need to have licenses in all these other states. So our licenses don't expand out. What that means is that sometimes if I'm seeing somebody from New Mexico, we might say like, hey, you need to drive up across the border. I often will follow up and say, I'm also not the FBI and we cannot track your IP address to know where your computer is at. Take that for a grain of salt. So you tell me where you're at and I have to believe you. And so far, that's where we're at. So that being said, we can do telehealth for that stuff. Occasionally, we would want to do an in-person visit. So sometimes, especially that intake, I think, to kind of get a good baseline exam, that's where you kind of want to see where things are at and get a good assessment. So we, that one, usually we kind of do that one in person. But a lot of times the follow-ups, as long as people are doing well and stable, there's a lot of hospitals and labs and MRI machines down here. So we can do a lot of stuff remotely, usually really pretty well. Sometimes, if the neurologists aren't there, and you have a good primary care doc, we're very happy to work with primary care docs. Sometimes it's less, and sometimes it's less the insurance in the health systems. The health system won't take an order from an outside doc that's not part of that health system. But if your primary care is willing to sort of reorder, the orders, then they'll just put them through under them. And if that works, then we can kind of be more of a consultant than a primary, than sort of a primary neurologist. I have a number of patients that I do that with. There's sometimes people that have sort of a local neurologist and they just see me once a year to kind of just touch base. Hey, like overall, this is kind of what we did this past year. Anything else, big picture that we need to do? For people that have had MS, that sometimes, you've done the same thing for 5 years and things aren't changing that much, right? And so as long as things are kind of stable, it's just kind of a quick touch point of like, hey, things are going okay. And so if it's every couple of years or something like that, just to kind of be like, okay, yeah, you're doing good. That works out just fine. So I think that the model can look very differently, and depending on sort of what you're looking for, it can depend.
In that same vein, what is there a value to seeing a specialist for a second opinion if you're in an area without an MS specialist?
Yeah, I mean, I think so it's some for anything that you do, right? There's people that like you wouldn't want to come to see me to treat your Parkinson's disease. I might be able to recognize Parkinson's disease, get you started on some stuff. But last time I really managed Parkinson's disease patients was probably like 15 years ago. So again, don't know, not the best option. So with all the drugs that are being available for MS, it is amazing to me sometimes it's less sometimes about the disease modifying therapies and just the symptoms. People coming in with a foot drop that hasn't been addressed, whether with drugs or devices, things, just sometimes to kind of look outside the box and try to come up with other ideas. We work a lot with advanced practice providers. And so a lot of times for patients that are coming up there periodically, we will alternate visits simply because the stuff they think about might be different than the stuff I think about. I like treating spasms. It's one of my things. Somebody else might be really good at bladder stuff, and so if we can tag team these things, you're going to get the best of both worlds. And so it's recognizing that, people do have those different specialties and, kind of being able to kind of think through those things can be really helpful.
The exact question that was asked for this one is, out of the host of alternative medicine remedies, are there any that have any credence? And I'm wondering if you can also elaborate on kind of the difference between some alternative things for symptom management versus disease management.
Yeah. So alternative therapies is kind of, so I'm laughing because we're reviewing these new patient packets a little bit, and Kelsey put in a comment about I think it was around yoga, and is like, are we still calling yoga an alternative therapy? I think nobody's going to argue with exercise as being an alternative therapy. I think it's part of what we're doing, and it should be a primary thing. So what's sometimes considered alternative versus, more mainstream stuff at this point, it's a little bit hard in Colorado maybe to think of cannabis as an alternative therapy when it's pretty much everywhere in every town. If there's 3 houses, one of them is probably a dispensary, it seems like. So I would say, as far as disease modification for many of these things, there's not any that I can really think that I would kind of consider alternative that has much data to it. I think there's a lot of good things, the exercise piece and doing a lot of these other things that, do, especially from a progressive perspective where there's less of direct effect on inflammation, but for maintaining strength and those kinds of things. Like anything and everything that you do for those things is going to help. So most of these probably fall more on the, I would say probably the symptomatic management of things. And I would say of kind of maybe those things that kind of fall a little bit more. So, the vitamin D thing we talked about, cannabis is legit, right? I mean, I think it's something that may not get recognized at the national level. I have issues with it being, not well regulated, somewhat regulated, but for example, the analogy I use a little bit is like aspirin. I would much prefer to do aspirin in a pill form than having to go and chew on some willow bark, right? Like that's where we got aspirin from. I've chewed on bark, I've eaten licorice roots, but I much prefer to have licorice as a gum or something else than having to chew on wood. So it's one of those things like, once it gets purified and cleaned out, then I think it even becomes better. You know what you're dealing with, how much to take. It just makes it more reproducible as to how you're doing it. We have seen pretty good effects with sleep, and helps with spasticity and spasms. It can cause fatigue, and those kinds of things. So it's a little bit kind of out there. Are there other ones that people are thinking about that would want me to blabber on for a bit about? Bee stings, that was a popular thing, I think, back in the 80s. Personally, I prefer honey. But, if there was nothing that came out of that stuff that was really evidence-based to kind of support its use. Kind of following that, I think there was also some things with like the Zamboni treatments around kind of putting stents in to kind of fix the venous flow in some patients, and this kind of stuff. And these are examples of things that sometimes, they get started in small trials, and then it takes millions of dollars to get the data to kind of say whether they're helpful or not. And that was a great example where like 15 years later, Dr. Zamboni finally came out and said, there's nothing to this, we shouldn't be doing this. But then people are still doing it because, somebody said that they had some good benefits from it. So for that one patient, right, just remember Ocrevus or Tecfidera or Augbagio did not get approved on one person getting better. And so there's something about when a drug gets approved, when a device gets approved, there's just the amount of data that comes into it makes it much more reassuring. And I had a patient who was doing intravenous ozone treatments, things like this. I think there's things that just need more data. There's things that sound crazy to me. We have a physical therapist that's applying tourniquets to people's legs or arms that are weak, and it's trying to then exercise them with the idea that it creates sort of that oxygen low level, like if you were exercising at high endurance, to induce growth factors that might be helpful. And so far, the small data looks amazing for it. Some of this stuff like hyperbaric oxygen and things like this, might be helpful. You just don't have the data for it. So my rule of thumb for these things are, if you have the money for it and you want to try it and there's not a lot of risk to it, I think it's worth sometimes trying it. But a lot of times they're very expensive and it makes it really hard to kind of get behind them.
What about prebiotics or probiotics?
Yeah, so the whole gut microbiome thing is something that's very interesting. So we interact with more bacteria than we have cells in our whole body and just in our gut. And so I think it's one of those things that it's sometimes the chicken or the egg. So there's been a lot of associations of like, these are good bacteria in your gut and these are bad ones. And some of these things is like they'll compare populations like in Africa versus North America and see like, North American diet, leads to these bad bacteria and things like this. The problem with bacteria is it's also kind of like what you provide for them to eat. So another example, maybe not a great one. If you don't eat beans very often, you don't get very good at digesting them. And so then you eat beans and you get some explosive phenomena that comes out. If you eat it regularly, then you can digest that much more efficiently and you don't produce as much gas because you just have the right bacteria that know how to do that and they don't produce the gas as a consequence from it. So if you're having things where you destroyed your gut microbiome, for example, you had a urinary tract infection and you got antibiotics for it, you probably killed a lot of the bacteria in your gut. Having some probiotics to try and kind of kickstart things could be really helpful. If you're trying to then do probiotics, but you're feeding them not for the whatever we think those are good bacteria, but for the bad bacteria, you're just going to keep selecting the bad bacteria. So probiotics can be good, but you also then have to feed them the right stuff to kind of keep them going. And so you have to kind of balance those two things.
Excellent. Thank you guys. Thank you everyone for great questions. We're going to go ahead and wrap up. We are posting a link to our evaluation form, and those of you in person have those in front of you. Please fill those out. I do read those and take every comment to heart. So thank you, Dr. Alvarez, for your time tonight, and thanks again for all your questions.
Yeah.